All right, so we are back. This is a joint meeting with Senate Health and Welfare and House Healthcare. And we have had some presentation of some really important and helpful information from the Milbank Foundation and from Elliot Fisher of Dartmouth, and we're very appreciative of that. But we also have with us members of the Green Mountain Care Board and the Healthcare Reform Director from AHS. And I think we have questions about what we've heard and the best way to go forward. So I have lots of questions, but I would like, if folks around the table would have questions, write them down and get ready to ask. I would like to start with the concept of the relationship of hospitals to our primary care. And I know that's something very important, and you brought up the blueprint, but how can we enhance one and keep the other? How can we not, damage our hospitals and keep our hospitals financially sustainable, and at the same time reinforce and build our blueprint for health, primary care? So thoughts on that, and I know it's just sort of an instantaneous question that you may or may not have thought about. Sure, you have thought about it, but any thinking there, just to start with that. That's one. And then the other question that I'd like to think about for all of us is we've been putting in place some regulatory principles for the board. Okay, so suppose it's a global budget, and suppose it's the per capita budget that folks have been talking about. Could be a CPI, could be any one of those, but it will be something. It could be something that helps to reduce the overall expenditures over time. How do we hold, where's the accountability in that? And who's responsible for overseeing that things actually happen? Well, that's a second question. I'll save my third. Not, just general questions. Do they resonate with you or not? If they don't resonate, just speak up and your response to what you've heard today or further information.
Let me introduce ourselves real briefly. So I know they already did. Owen Foster, I'm the chair of the Green Mountain Care Board. Dr. Mermer and I started the same day, October 1st, 2022.
I'm Brendan Krause, the director of healthcare reform at the HHC of Human Services, and I started in July of 2024.
And I'm David Merman, Green Mountain Care Board member, started at the same time as Owen. And I just, as the chair is I would say beyond a full-time job, I have another position as well. I work as an emergency physician at CDMC. And I think that just want to mention that, I think it brings some of my perspective to to a lot of this work.
So I'll start with the primary care question. I was excited to see the mention of the blueprints. And one of the things that we've been pretty actively thinking about and talking about in committee with all of you actually, is how we can better leverage the blueprint as sort of this blueprint 2.0 concept that you had, Chris. We very much see the blueprint as what's most famously known for its primary care medical home model. It's also very potentially an engine for delivery system transformation. And you can see that in some recent expansions that have occurred in mental health, embedding mental health in the primary care medical home model. So we very much see the blueprint and the Vermont Chronic Care Initiative and their related field services as a platform upon which we can build and tie into the transformation agenda of primary care integration into the model.
On the primary care and the relationship with hospitals in Vermont have a lot of the primary care in the state. We're trying to support primary care everywhere. We're agnostic as to where it is. There's a lot of benefits to having it at FQHCs or independents. They're often more affordable for those services. And they also send referrals to any number of different places, whereas often you'll have hospital referrals for primary care to hospitals, which may be more expensive. But nonetheless, our view is that we need primary care as much as we possibly can. And the board has taken a lot of steps to look at productivity and operations where we can improve our access to primary care. The UVM Health Network has done a lot of work, or the medical sector rather, recently on improving access to primary care, which we think will start to pay dividends in the next couple of years.
I'll take a shot at the primary care piece because we've been working on this a lot, both at Millbank and in my prior life. And that's where I interacted with the Blueprint for Health a lot. I think two things, a reality around primary care, besides the numbers and the difficulty of the work, is that a significant number of primary care clinicians, I don't know what the number is in Vermont, are employed by the health system. So when we think about strengthening primary care and building out primary care, how do we do that in the context of an employed relationship with a larger health system? And I think two things that are in the Blueprint bones originally that are worth holding on to. One is a community-based approach to strengthening primary care. So a hallmark of the Blueprint has been when we gather folks, when folks are gathered around primary care, they're done in the context of some sort of geographic catchment area. So we're bringing all the primary care providers in St. Johnsbury or in Rutland, or as many as we can possibly get. We're not relying on the health system or the employers to convene them. So that allows you to kind of keep the focus on the community and the social determinants of health. It also breaks down some of the barriers. The other thing, which is harder, so that has to be supported somehow. Department of Health, you need people who are going out and meeting with them and feeding information and producing the data to say, here's what's going on. The other thing that I think is even more important is the flow of money. You have to think, you not only have to provide money to hire an extra care management nurse or some little piece, do some training. You have to think about how the money flows to the practice, preferably attached to a patient. And that's really what Blueprint worked on. And it's a real challenge when half of your, it's not so much a challenge with health centers because they're used to be held accountable, but when you have a health system that's employing primary care docs in a bunch of different places, especially if they're geographically diverse, how do you make sure that money actually goes to build primary care capacity, especially when you're paying it to the health system? And that's no knock on the health system, but in a number of states, they're telling payers, look, increase the money that's going to primary care. And the payers pay the health system, and no one knows if the money is actually making it out to the primary care docs. And I think that's something to think about as you do it. And it is possible, but you need some state oversight to make it work.
When you say health system, you are thinking about where is that money going?
Yeah, just think about the I'll do Rhode Island because that's fine.
Yeah,
half the docs there are employed by health systems, meaning what we used to call hospitals.
Okay.
So I'm cutting a check, I'm telling the payer, go cut a check to benefit primary care.
Yeah.
It's going to the health system, and then I run into the primary care doc in the grocery store, and she says, "My life's miserable. I'm not seeing any of that money."
You're actually getting to a place, I think, where there are a lot of questions about how do you follow the money within that system.
Right.
So and I'm looking at the board, the questions about that in terms of Oliver Wyman report said a single audit and a single way of looking at folks. And we've seen recently the disagreement out in the media about UVM Health Network, UVM Medical Center. And how is the money followed? How would it be followed? Or what are your suggestions from the board perspective?
So there's different money. This has come up as a regulatory issue for the board in the context of the ACO. There's population health management payments from the ACO out to hospitals and to support primary care. And that was exactly something that we looked at, which was what Chris is touching on. It went from the ACO back to the hospital. Did the money at the hospital get to the primary care providers? Did it go to support primary care? The truth is we weren't able to get that level of granularity, and we required it as a board condition to certify that the money was actually getting to primary care. And there were some starts and stops in the information as to whether or not it actually was. But then outside of the ACO context, you just have regular rate increases, and that is something that we do not go that granular. We give a hospital budget, a rate increase. How they allocate it is within the hospital's purview. But in Vermont, many hospitals have pretty good discretion as to how much money they go up or down on rates, right? So historically, you've seen a hospital say, okay, we want to go up 20% on this service, down 2 here, or up 5 here and flat here. It's not like when we give a rate increase of 5%, it goes across the board. And so that is something to think about when a hospital is allocating its rate increase that it gets and its commercial prices, where is it putting it? And is it flowing through to what we're trying to drive at as a state, including primary care?
And I would say that in Blueprint, it's a little different because those payments are tied to specific initiatives and issued by the Department of Vermont Health Access. So it's a little bit cleaner for us, but that's obviously not systemic. It's share of hospitals, ACOs. The systemic adds to the Blueprint.
Yes, I mean, everything makes sense here. So I want to turn to Representative Cordes' question earlier about what's happening. And we'll come back to your question, Representative Rebecca. But your question earlier about what we're seeing in terms of budget decisions being made and then affecting a reduction and causing a reduction in services. Do you want to read?
Yeah, before you go in the room, I had asked about a comment was made earlier about the economically rational decisions that, speaking about my own hospital, UVM Medical Center, made to the Green Mountain Care Board request to, or edict to lower cost. And then what the steps that happened after that with the hospital focusing on net patient revenue, which translates into the hospital cutting census. Not because there is less need. On my unit, the cardiology unit, there's still people waiting to get in to receive inpatient cardiology care. But the arbitrary reduction in census is causing the backup of people waiting to get in for care. And then, of course, the primary care practices and the potential loss of the outpatient dialysis clinics, which has been an issue for the hospital for many years since they first tried to sell to Fresenius. So it feels like another squeezing the balloon problem. But I'm concerned about that kind of response because it's not, it's reducing access to critically needed services. And so I do support however we do it, more of a unified system or approach where we can get folks that need to be at the table, making really hard decisions. And I was joking earlier that maybe we'll know we've succeeded when everyone's mad at us.
Some thoughts and response, and how do we get there? Yes. Short question.
I think, so the concern is really that if there's a cost containment effort, it is the result of the cost containment effort to lose services, and what services are we losing? So I can speak to our enforcement order that goes to this, which discusses why and how it was done. And what we look at and consider is, do you need to cut services in response to this cost containment effort? And the answer to that could theoretically be yes, but that would presume, one, that you don't have the money to withstand the losses. Two, that you're operationally highly efficient. Three, your clinical productivity is very high level. And four, that you have reasonable prices. And when we made our decision, as we discussed in the enforcement order, we saw a number of opportunities to improve aside from cutting services. and we laid those out. You know, when we don't have control over what services are specifically cut. It's not it wasn't part of this budget process. We might be looking at it in the future as to whether or not we can. But we saw really significant financial gains year over year. And we saw some monies owed, and we saw some productivity that could be improved, operational excellence could be improved. And we felt that those could be addressed first. And that's not where it went, but that's what we do in our orders. We say why we think that this reduction is appropriate. Does that answer?
In a reduction in cost of services, a reduction in the cost of some services was also a.
Correct. So prices, commercial prices. There's some metrics we look at, national data we look at. And if a hospital had very low commercial prices, is it appropriate to reduce their price request? I would say in this environment, that's a hard decision to do. If the prices are very high, already very, very high, it's a different conversation. And then you do look at what are the assets available to cover losses. And if the assets are $1.3 billion, can you withstand a $2 or $3 or $4 or $5 million loss on a service that's important to population health in the community? My general opinion would be in the short term, yes. In the long term, that might not be a sustainable path. But we look at the financial health of organizations at large in making these considerations.
Thank you. So we've had Representative Black, Representative Robeco, and then Representative Houghton. So we've got everyone on deck, and if you have a question, just let us know.
Could I have one code of that, if you don't mind? So
Yes, sure.
also, as we work together on transformation, these decisions have to be thought in the context of the whole system as a whole, right? So if you have sufficient mental health access elsewhere in the state, maybe that's not suggesting it's not, I don't know the answer to that question. But you have to think about it together with the broader role.
Thank you. You guess a statewide health plan of some kind, isn't it?
So in light of many of the things that we've heard from all of you, it seems as though when you look at past efforts at transformation, particularly around primary care, because we know we have a crisis of primary care in the state. It feels as though we've incentivized hospitals to sort of expand primary care. And as Chair Foster has just pointed out, we know that primary care in the setting of a health system, a hospital health system, it's more expensive. It tends to have, I believe, with our all-payer model, lower quality outcomes, limited access. What levers do we have as a state to incentivize the removal of primary care from hospital health systems? You just talked about with the ACO, the incentives, and we don't even know when it's paid to a hospital health system, whether that money is going to expand primary care. The blueprint community health teams are administered by the health systems, and oftentimes the community health team member is employed by the health system. Is that the most efficient use of our dollars? To your point of providers being employed by health systems, I think one of the things that we also know is that it's easier to be employed by a health system because frankly, the administration of running your own practice is, I've never met a doctor who went to med school so that they could, deal with healthcare financing. What can we as a state do to incentivize the removal of primary care from hospital systems, grow our primary care workforce, and also support primary care in the business of running practices? Does anyone have any thoughts around that?
I can start on that. I think that as you point out, primary care that's delivered outside of a hospital system tends to be far more cost effective. It's less expensive for commercial insurance, Medicare. I don't know exactly the Medicaid payment in Vermont. So I think expanding and supporting primary care outside hospitals is really important. What I wanted to mention before, and I think how to do that, I think is complicated, and I have some ideas that are sort of just, the ideas of one board member ideas and not, things that I think we have.
Definitely have you in to testify. Looking for ideas.
But, I lost my train of thought of what I was going to say about hospital primary care from before. Oh, I think that, yes, it's far more cost effective to do this in outside of a hospital-based system, and the supports that we need to do that are important. As we talked about before, the hospital primary care relationship, our hospitals are really dependent upon the primary care services that are delivered outside the hospital. Community health centers of Burlington, I think, is a really good example. If community health centers of Burlington were to implode, let's say, UVM Medical Center would be completely overwhelmed. So the services, they are interreliant on each other, but the FQHCs are largely across the state are very financially struggling right now, and they have solvency issues as well. So, I think actually the healthcare transformation team would probably be better to speak to how you can directly fund those practices. But I think my focus would be on expanding what's available as opposed to removing from a hospital entity. I think that they actually, while more expensive, there are a lot of good integrations they can do.
So while you're on that topic, the governor's budget includes millions of dollars that will theoretically go to FQHCs. I see that as transitory, stopgap, and not anything that can continue. And so I'm not asking a question, I'm stating it. From an appropriations perspective, we can't do that. We can't pay every hospital and every FQHC to stay alive. It is important. Your comment about the FQHCs, and in particular the Burlington, because that's where I am. That's where not my district, it's in Senator Gulick's district, but it is critical to keep them alive and to ensure that the money that's going there is sufficient to keep them alive. But I didn't want to co-opt other folks who have questions to ask.
I think I'll ask a question to my colleagues. It does seem that having the data about where the primary care money funds are flowing and through what elements of the hospitals or however, I don't know whether they all have defined corporate entities that within which the physicians are billing. Often they're billing under a medical group, even though the money gets paid back. But I'm curious to understand what the structures of the hospital primary care system, hospital associated primary care delivery systems are, where the money's flowing, and then think about creating a unified view of primary care funding and assets and resources to support the transformation planning, because you need that foundation. And it seems like the black box of the hospital's delivery of primary care keeps us from being able to do that kind of thinking.
And if I may, that gets to Elliot's in his presentation about planning and evaluation function. So if community-based primary care is a priority, what Elliot's asking is, well, what do you have right now? How do we know so that we can measure it and how it changes? And that means, in addition, to bailing out financially distressed providers, we have to have the ability to measure so that we know if we're making improvements in it over time.
And I think it actually goes beyond primary care. I think, and Elliot and I were talking about this earlier this week, I think if you look at Vermont's experience with an ACO versus other states that have more successfully sustainable ACOs in terms of quality and cost savings, we don't really have a lot of non-hospital based specialty care. We don't have a lot of places to do that care coordination that's not in otherwise it should be an inpatient setting with the fixed costs associated. So, I think that there is an opportunity, and, sort of looking back at FQHCs, we're lucky we have maybe struggling, but a robust infrastructure of FQHCs that look more like multi-specialty group practice than anything else in the state. From my perspective, are there ways to build sort of the good parts of ACO theory and tactics in terms of analytics and administrative streamlining and funding, you know, around those institutions that would positively incentivize care moving to the community.
A friendly amendment, we have to change the name in Vermont.
Oh,
Population Health Organizations.
yes. Oh, right. That's what you call it. Okay, yeah, that's it.
Okay. We're going to move on to Representative Rebecca, and then we'll go to Representative Houghton and Representative Chena. So Representative Rebecca, you're on.
Very good time to know you're referring to the CCHCs like we did in Vermont. I'm wondering if anybody can help me understand in all of this discussion of payment reform and hospital transformation, where does mental health fit in? Because I find it hard to believe that we can talk about payment reform and not be talking about quality, which has a huge impact on affordability, right? We're not talking about caring for people in this conversation at all. We're not talking about the fact that, you know, we can't really be addressing the ability or the accessibility to services while not truly talking about addressing the demand. And I think if we're not talking about how people come into hospitals, including the people who shouldn't be there, you know, we're not really gonna close the nozzle on affordability of hospital care. So can someone tell me where mental health fits in and substance use disorder care fits in? I know the blueprint is one option, but the blueprint's been around for a while and it's clearly not reaching everyone who needs it.
I can just quickly say, you know, in the context of payment reform, that's one of the explicit goals of a head should, you know, that actually, you know, take effect and and the state get access to the additional flexible funds. One of the highest priorities will be improving and expanding access to mental health and substance use. So it's very much on the roadmap, but others could.
Comments first. If I look at what Intermountain or other systems, and I think we'll hear more about it, they really are trying to think about population they're serving, you know, just the way it's who are the people responsible and how do we meet their needs. I think the model that has been proven very successful for behavioral and mental health services is their integration in primary care. And I think one of the things that has not been thought through, and maybe you did it in Rhode Island, I'm not aware of it, but how to make sure that what, you know, primary care and mental health care, you know, basic community-based mental health care services are delivered. And I'd put those in the bucket of primary care. And I don't know if that number, you know, people have been talking about an 11% target instead of 5% target for primary care funding, but it should, I would include in the target. And I see Brendan nodding, you know, what's the budget for great primary care and behavioral health, necessary behavioral health services? I would mention that severe mental illness, I kind of put in this. I think people should think differently about them.
Yeah.
There's such a different level of service that's needed. But
did that factor into any of your, you know, consideration when you're talking about, you know, transformation of Vermont's system?
perhaps not today as explicitly, but I think strengthening primary care has to be done in parallel with how you're redesigning the hospitals. Because we won't need, you know, much smaller hospitals if we got primary care right sized and kept people out.
And a way to think about that, this might be what you're saying, is the definition of primary care is called comprehensive or advanced primary care, and that includes the ability to treat low acuity behavioral health with integrated behavioral health care. And that's the blueprint as conceived is it's an ongoing process to try to create more comprehensive primary care. And so what I heard in your question is some concern that maybe the blueprint hasn't done that for behavioral health. Then we have to think about I'm not sure it's legislative action, but that's what's in that definition of comprehensive primary care does include behavioral health, and how do we improve the capacity of these primary care folks to provide it. Since I got the talking stick, I just want to know, really, since we've been talking about primary care. Primary care is a relationship between the family and the caregiving team. In public health, which struggles with this being kind of moralistic, they use the language, how do we make the right choice the easy choice? So if the right choice is for folks to have primary care, how do we make it the easy choice? That gets to questions of benefit design, maybe how do you create financial incentives for people to use it? All that is part of, if you want to have a less institutionally based, specially based, we've got to make the right choice the easy choice. It means looking at scope of practice to make sure that everyone's practicing at the top of their scope. It means measuring. So it means looking at benefit design as part of what gets built. So I found that relationship, thinking about primary care relationship, to be really helpful. So and relationships are a two-way street. So we got to get people to commit to, we got to make primary care available. We got to get people to commit to it.
Thank you. Well, I'm sure that both our committees will be continuing discussion on mental health issues, and obviously the hub and spoke that's been going forward, and the integration of community services with social and medical integration has become so critical, is critical. I'm going to go to Representative Howard.
So thank you all for this. It's fabulous information, a lot we have to dig into, and it's charting a long-term course for us to continue with transformation. And quite frankly, I'm really worried about the crisis we're in today. I want to go back to that. High costs, access issues, teetering on quality issues, not being able to track those very well. We can do reference-based pricing. We can do global budgets. That's capping a system that we know, is trending, their financials are trending down. It's not helping us move money into the community supports where it is cheaper. And we can, so I just feel like we're coming up with these long-term solutions that in the short term will create bubbles like we've talked about. And we are in a crisis today. And as Dr. Merman said, we have an FQHC that goes out at Burlington. UVMMC is in dire straits. If we have health insurance companies that can no longer function in the state of Vermont, what do we do? So I'm looking to all of you very smart people who have a lot of history to help guide us in the today as we plan for the future.
COVID.
Okay, so you just asked a great question. You left in silence.
And I mean, there might not be an answer, but I think that needs to be on the table.
No,
We learned a lot in COVID.
Yeah.
About emergency planning. Pull teams together that are diverse, that have the various players who could make a difference, whether it's in the executive branch, the hospitals, the community clinics. And you say, we don't know what's going to happen with the federal government. We can't have prices go up like this. And what if and let's just start, Vermont was a great model. I love listening to the press, to the morning the governor's press conferences. I'm just thinking, you take an emergency planning model, or a short-term planning model. Maybe it's not an emergency, but we try to say, what could the board do in this next budget cycle to help slow cost growth? What could the blueprint of the governor's office do to strengthen primary care? And where are the emergency? Wait to gather the data from my wished-for planning agency. It's going to be too late. What data could we have now from each of the FQHCs to know their balance sheets and days cash on hand, and figure out who's really the emergency that we need? So I think of the COVID model, even though the time frame might be longer, but if they decide to unfund Medicaid, we'll have that model on our hands soon and fish.
I can speak to some of the things we are doing currently every day because of this crisis. So one, in the last several years, we've been trying to get a lot more information about the broader system. So I can tell you how many days cash on hand Howard Center has, Little Rivers, community health centers. And the board has informed itself, it's put in a lot of effort to be more aware of the broader system as opposed to the one we regulate, which is the hospital system. Because when you make those decisions in a silo, you don't make the best decisions for the system. Okay, we've done that, and now we're taking different actions with our regulatory decisions, acknowledging this issue. There's a lot of reserves in the system, actually. It's just that they're concentrated in certain pockets, and they're not really being utilized to sustain the entire system. So if we look at some of the board's decisions recently, we've really reduced the commercial rate increase for hospitals significantly. I think system-wide it was 3-4% last year. The year before that, it was what, 8, 9, 10%, something like that. So we've reduced that. That will make it more difficult on hospitals, there's no question. But the upside of that is some of those FQHCs and some of the primary care that's independent was able to get larger rate increases than they ever had before. So we've balanced it out a little bit where the broader system around hospitals can survive a little bit better. And you talk about Blue Cross's solvency. This is a domino. You lose any of these things and it's a domino on the system. So we're acting in a crisis situation in our decisions. We gave Blue Cross a very large rate increase last year, recognizing that if it had a bit of a problem paying claims, everyone was in trouble. And then the other thing we've looked at is, the enforcement decisions that Representative Cordes asked about. Well, that was a painful decision. It's really hard on UVM, but it helped stabilize and support Blue Cross's ongoing concern, and it helped create money and available money to pay others better. So it's just, we are trying to, in every decision, balance this sustainability of everything. And it's very, very difficult without any more money to access. And there's pain when you do it in certain sectors.
I think so, sorry. Yeah, I would say similarly, there are a lot of activities that the HHS teams and the departments are doing every day that, I might not mention this often as I should, but, they're also, daily monitoring sort of these excess and cost issues, convening with FQHCs. It's other activities like, some of which were on the latest slides, but, working with the hospitals to improve transfers of bed blocking patients who are bed blocking, say UVM. When there's capacity in other hospitals, that would be a win-win for the system. That's very short-term, but very tangible and very cost-effective. Similarly, reduction in ED utilization through some expansion of some community-based interventions, for example, the recent mental health expansions, et cetera. So I do really think that and then there's sort of I think probably where we're all going to start is looking at those administrative costs across the board in terms of, sort of high value, low cost, rate reduction. Cost reduction. So I think there are things we can do fast while we plan.
And may I just follow up?
Just quickly.
And so I appreciate all of that. And I know it's hard work and I want to make sure everyone has what they need to be able to succeed. And I will say, I like Elliot's suggestion that we go back to our COVID mode and we start doing some emergency planning. As smart leaders trying to find a solution to get us through this crisis, who knows what else will be coming our way, and ensure we have the system here as we transform it into the best that will bring more people into the fund.
Point well taken. And I will say that we will be looking at a committee bill that will include some of what you have just said in terms of what can we do in the short term, an emergency, and then moving forward. And you folks are going to improve it when it gets over to you. But Representative Chena has a question.
You have 2 questions. The first one is probably the easier one. It has to do with spending on primary care. Several years ago, before the pandemic, Rhode Island was doing work on shifting spending towards primary care from the hospitals, and I was doing some internet research while waiting for the question to look at where they're at. And I'm not going to report to everyone what I saw, but it looks like they had a problem during COVID and now they're getting spending under control again. So I'm curious if there's any lessons for us to learn from Rhode Island or other states around how to shift the spending towards primary care, since that could help the long-term population health outcomes and save money in the long term. But then similar to the question you just heard about an emergency, I guess the question is, at what point do we recognize that there's a public health emergency again? Like we're seeing with unsheltered homelessness in Vermont, a burden on the healthcare system. And we're seeing diseases spreading again, like new forms of COVID, potentially an avian flu outbreak coming, like if we are not prepared for that, so I guess the question is, at what point do we declare a state of emergency and then use the medical reserve corps again to fill in the gaps and use the National Guard to step in and help address some of the issues? And that could alleviate some pressure on the system as a whole while we then fix the problem. And so I don't know, those are just two things we can do in a state of emergency, but there's many others. Like I saw in 2 days, us change all the regulations and rules. Like we passed a few emergency healthcare bills in like 2 days that, affected things from provider taxes to other kinds of regulations that I don't need to like repeat. So I guess just putting that out there, number one would be, at what point do we declare a state of emergency and what might be the things that we could do in a state of emergency? What might be the resources we use to take pressure off the system while we fix the system? And the second piece would be, what role would reinvestment in primary care play? That makes it, just to
But, and what we're going to do is we're going to let them respond to that because we need to finish at 5 of and no later. I want to just bring closure to the meeting because I know that Chris Kohler has a meeting he has to get to and need at least 5 minutes between now and then. I get it.
Can I take a shot at, thank you for your primary care spend question, because that's that's my baby. I think they might put it on my gravestone, keep up with it in Rhode Island. We landed on primary care spend as a concrete, easily understandable way to focus on the need to build community infrastructure. What portion of the dollars are going to primary care? And there are comparisons with other countries and high performing health systems. You're asked to your point about what are the lessons from Rhode Island? Persistence. So I'm not aware that that primary care spend in Vermont is one of the key indicators that Vermont Health Access or Green Mountain Healthcare Board is measuring on a regular basis and then holding people accountable, holding entities accountable for. So Elliot was talking about quality improvement gurus. You improve what you measure. And so and I would argue that primary care spend continues to be it's a measure of progress. It's also a way to focus people's attention because most people think we spend a lot more than what we do on primary care. Rhode Island has made some measurement tweaks over time. How do we what's in the denominator? How do we deal with people who are getting their care out of state and stuff like that? But the big thing is you just got to stay on it. You got to keep at the top of your list. And it's actually pretty easy to do if you can remember to keep doing it. So it is, and first you measure and then you set targets for what it should be. I think you hold health plans and the payers accountable for it, but you can also hold the health systems themselves, get past the payers into the health systems. But it's the high performing Medicare ACOs, they're all spending a ton of care, way more than what everyone else is doing. So I think you just got to stay focused on it.
Thank you.
I'm not going to do the public emergency.
We won't, the emergency piece is something for us to consider around the table and how we do it is going to be.
Also, the air quotes emergency.
Yes.
Maybe the thing is, what did we measure during COVID? How do we know we were making progress? It was ER visits, it was vaccination rates. I'm sorry that the rep is left, but what are our key, if this is a crisis, what are our key measures? What do we want to see improvement on?
Cost, quality, access. How do you do it? Exactly. You have 1 minute, Representative.
Since we brought up COVID, one of the reasons that we were so successful here is because the federal government stepped in with a lot of money.
Don't lose that Medicaid right now. Keep your eye on it. That would be one of the.
No, Medicaid is good. Yeah.
Point, sir.
No.
So we won't go there right now. We're all apprehensive about what is going to happen at the federal level. Understood completely. And we have to focus on what we can do here to improve the system in Vermont. And then we will also be keeping an eye at the federal level and work to do what we can do there as that happens, when it happens. Be there. Good question. So I just want to say thank you to both committees. It's been very helpful. I think it's been helpful. You folks have been more than helpful and can't tell you how much we appreciate your sharing your wisdom with us. And this isn't the end of it. As I said before, our committee will begin a bill. We're working, I put together some stuff. And everyone who's in the room has helped me inform that. And then we'll be reaching out to each of you again for help. So because we are in a crisis, we said that in the beginning, and we know that we need to act with alacrity and with alignment. So, so thank